Good evening, friends. My name is Dr. Raja Dhar, and I work as a consultant pulmonologist in the CK Birla Group of Hospitals in Kolkata. Today, we are here with you to speak about a topic which is not often spoken about, but very important in our mind. We're going to talk about early lung cancer. And when we talk about early lung cancer, we'll divide it into two parts. I will talk about lung cancer screening, and my colleague, Dr. Nagarjuna Maturu, will speak about diagnosis of early lung cancer, and he'll speak about the fancy tools which is related to this diagnosis. Then we'll have a panel, and in the panel, we'll discuss about facets which are relevant to our country, relevant to all of you in the CCI team and beyond. We'll talk about how, in an Indian scenario, we use our various tools, we use our clinical acumen in diagnosing early lung cancer, and also the way forward in screening, which is still in a nascent stage in India. Chest Council of India has been doing these meetings now for a very long time. And the Thursday meetings have become a popular spot for chest physicians throughout the country. Before I start off, let me do a quick round of introductions for my fellow panelists and colleagues in this meeting. So Dr. Nagarjuna Maturu is a consultant, clinical and interventional pulmonologist at the Yashoda Group of Hospitals in Hyderabad. Nagarjuna has earned a name for himself throughout the country, not just about interventions, which he's brilliant at, but also with his acumen in all of respiratory medicine. So Nagarjuna will be doing the second talk. The second person, the lady in the team today, is Wing Commander Dr. Anuradha Ahuja. Dr. Anuradha Ahuja, as you all know, is from the Army Hospital R&R Delhi and is the CCI state head for Delhi. Anuradha, again, is one of the brilliant minds in pulmonology today. She's done great work, both in R&R and also in popularizing respiratory medicine across the country. My third colleague today is Dr. Kamaljeet Singh. Dr. Kamaljeet Singh is an assistant professor in Kanpur, Kalan, Sonepat, Haryana, and he is a young pulmonologist who's got great acumen, and a lot of people want to hear what Dr. Kamaljeet Singh is going to say today. So that's our panel today. We'll come back to the panel in a minute, but we'll move on and we'll start off with the first talk. I hope the slides are visible to all of you. Are they visible to all of you? Yeah? Okay. So that's my topic today. I'll talk about non-invasive diagnostics and methods for screening. I'll mainly talk about screening. The diagnostic part would be up to Dr. Nagarjuna Maturu. So that's what I'm going to cover. I'm going to cover CT screening principles and evidence. I'll talk about other non-invasive diagnostic approaches, and I'll discuss an outline of how to minimize procedures in screening and in early diagnosis, which would be an introduction to Dr. Nagarjuna Maturu's talk. So I'll start off with some questions. These questions are rhetorical, but I want you to, when I read through these questions, and there'll be a few as I go along in this presentation, I want you to try and answer these in your own mind. So the first question I pose to all of you is that 5 or 10 years survival is a good measure of how effective the screening interventions are, because it means more people are being cured. So question, is a good measure of how effective are, because it tells you whether people are being cured or not. So I hope you've got an answer. Hold that thought, and I'll try and give you an evidence-based answer. So these are looking at studies. These are looking at studies from the 1980s, from the Johns Hopkins project, and this one project. They looked at chest X-ray, looked at sputum cytology, and they looked at a population which they thought were, and looked at the numbers. The 5-year survival was thought to be 35% in the group which was not screened versus 15% in the group which was screened. So a 20% advantage is what was envisaged. So that shows that screening in the way I described has a survival benefit. However, this is the meta-analysis which looks at all the studies put together and whether mortality is reduced or not. And if you look at these 6 studies, which together cumulatively account for about 25,000 people who were screened, there is actually no difference in mortality. So answer to the first question is, looking at 5 to 10 years survival is not a good indicator, of screening. Mortality is, and that's what we're going to pursue as we go along today. So why do we say that the survival is not a good indicator of screening? So the biases that I'm going to talk about, 3 different biases, will tell you the reason why. So the first one, the most obvious one, is lead time bias. So what is lead time bias? So think of patients who are not being screened for lung cancer. These patients, one of them in this particular study, out of 5, develop symptoms. Once they develop symptoms, the diagnosis is confirmed. Once the diagnosis is confirmed, over a period of time, with or without treatment, the patient dies. So that's the natural course of disease. 1 out of 5 individuals being followed up, not being screened, but being followed up, have symptoms, diagnosis confirmed, and then death. The time between diagnosis and the patient dying is the survival time of that individual. This is in the non-screening population. 5 people, again, 1 person after being heavily screened has a diagnosis confirmed of lung cancer. Look at diagnosis confirmed in the control arm versus diagnosis confirmed in the active arm, which is the screening arm. And you can see that there's a finite improvement, early diagnosis of cancer in the group where screening happens. The patient dies, and if you look at survival time, the survival time is much longer, even though in both the groups, the patients have died at the same time. So the survival looks artificially longer in the screened group because of screening, the diagnosis early, and hence the survival time is longer. So that's lead time bias, which I guess is obvious. And the difference between the 2 groups, as you see on that slide now, is the lead time bias that I spoke about. The next is length time bias. And this is something I want you guys to understand because it's going to be important in your clinical practice. Think about tumors across the board. Think about the various forms of lung cancer. If you think across the plethora of non-small cell and small cell lung cancers, you know that there are more aggressive tumors, tumors which progress and metastasize early, and you have more indolent ones which grow at a much smaller rate. If you think about the sort of going from carcinoid tumor to small cell, you go from that aggressive tumor mode to that indolent tumor mode. The onset, the detectable symptoms, this gap is different across aggressive tumors to indolent tumors. Now, if you talk about screening, when you screen at 1 and 2 years, between the 1 year, 2 year window, so that's the window that you see on the slide in front of you, you will have more of the indolent tumor rather than the aggressive tumors. A lot of patients with aggressive tumors would die if even before they get screened between 1 to 2 years. So screening at 1 year, screening at 2 years, you get a lot of indolent tumors in this span of time, and hence survival seems to be artificially increased because you're getting more of these indolent tumors rather than the aggressive tumors in this time span. So that's about length time bias. Indolent tumors being diagnosed more on screening as compared to aggressive tumors. The third variety you have is the overdiagnosis bias. So this again is a bit of common sense, but let me talk you through this in the next minute or so. So 2 groups again, you have the screen group at the top this time and the control group at the bottom. So with the screen group, you have 3 individuals who are diagnosed to have lung cancer on screening. Post-diagnosis, these people will die at some point of time. Now, because you have a diagnosis stamped of lung cancer due to screening, when these individuals die, the reason attributed to the death is going to be lung cancer. Now think of the control group. In the control group, out of the 3 who had lung cancer, only 1 presents with symptoms. The other 2 do not become symptomatic and die from other causes even before they have presented with lung cancer. So here you're attributing 1 death to lung cancer as opposed to 3 in the screening group. And because you're attributing 3 deaths to in the screened lung cancer group, you seem to have a longer time frame for survival as compared to what you have in the control group. So that's overdiagnosis bias. Overdiagnosis, because these patients have not actually died from lung cancer. You have found lung cancer incidentally on screening. They've died from other causes, heart causes, kidney causes, brain causes, and so on and so forth. So that's overdiagnosis bias. And because of these 3 biases that I spoke about, measuring survival as an index, as a measure of screening is not the right way forward in our individual patients. Let's now talk about a few trials, and I'll try and talk slowly through these so that you have a handle of what is right in our population when we go on to our panel discussion in a little while. So this is the lung cancer trial that's quoted the most. This is the National Lung Cancer Screening Trial from the US. This is quoted because this had more than 25,000 individuals who were screened. And I want you to see this carry home slide that I have selected from you. The 2 lines on that graph, one was screening with chest X-ray and the other was screening with low-dose CT. And even without going into the numbers, you can see that number of lung cancer deaths was lesser in the group which was screened with low-dose CT as opposed to the patients who were screened by chest X-rays. And you can see the p-value at the bottom there, a p-value of 0.004, which indicates that even though the numbers are not massively different, 309 versus 247, the p is 0.004, and the number needed to treat is 320. So what does the number needed to treat mean here? It means that if you screen 320 individuals, you're going to prevent 1 lung cancer death. So that's impressive. 320 people screened, 1 lung cancer death prevented. For a screening, that's a good number. So another question to pick your brains, again, question more to myself, but I want you to think about this because the next section will be discussing this. So all-cause mortality is reduced in breast, colorectal, and lung cancer screening. Do you actually agree or disagree with that statement? So lung cancer we just spoke about. What about breast and colorectal along with lung cancer? Is all-cause mortality reduced in all of these diseases? Remember, breast cancer, colorectal cancer, screening is something that's standard throughout the world. You would get screening either in high-risk populations or across the board in all individuals in breast and colorectal. So let's see what the data shows. So I've shown you the data from NLST, the National Lung Screening Trial just now. CT versus chest X-ray, the reduction in all-cause mortality is 6.7%. So 6.7% reduction in all-cause mortality if you screen for lung cancer in the National Lung Cancer Screening Trial. Now look at the data from breast cancer and colorectal cancer. I'm sure this will startle you. Like I said, these are standard cancers for which screening is available in most of the developed and some of the developing world. So this is 13-year of follow-up data for breast and colorectal. And you can see the hazard ratio for both breast and colorectal is 1 or very near to 1, which means that even though we screen for breast cancer and colorectal cancer at 13 years, all-cause mortality is not reduced. Now that's startling, and it gives us leverage. It gives us a justification for doing the panel discussion and the meeting that we're doing today. Lung cancer actually causes greater reduction of mortality as compared to diseases, to cancers in which screening is thought to be standard. However, there's a lot of criticism for the National Lung Cancer Screening Trial, and hence other trials being done later, which I'll speak about in a minute. Why is the National Lung Cancer Screening Trial not so convincing? The reason that lung cancer, and this is my thought, the reason the National Lung Cancer Screening Trial is not convincing is because the people who started doing the trial, the mindset was that CT scan, low-dose CT scan would not be useful as a screening tool for lung cancer. So that's what they thought. And because they thought that, they stopped screening after 3 rounds. How daft is that? You remember for colorectal and breast, we said 13 years follow-up. This trial was done for a year, and after 3 rounds of screening, it was stopped. People across the board were screened. So both low-risk and high-risk individuals were screened. Any nodule was referred to the clinical team, and hence, even small, anything above 4 millimeters in size was referred to clinical teams, and hence, these patients were over-investigated even for apparently and obviously benign lesions. And they did not use the best nodule evaluation techniques. Dr. Nagarjuna will tell you all about nodule evaluation techniques, but they did not use the best of nodule evaluation techniques, which Dr. Maturu will speak about in a bit. And we today can do much better than what NLST did. So what's better? This is the Nelson trial. This was an RCT of CT screening versus no screening. So unlike NLST, Nelson is CT screening versus no screening. There's no chest X-ray here. The population I want you to look at, it's 50 to 75 years of age. It's people who've got a more than 25 pack-year history of smoking, or if they're ex-smokers, they should have a 30 pack-year history of smoking, and they should have quit within 10 years. So ex-smokers, but within 10 years is the number. Unlike NLST, and that's the strength of Nelson, CT was done at 1 year, 3 years, and at 5.5 years. Much smaller trial as compared to NLST, about 15,500 patients randomized, and 7,900, so about 8,000 people who were randomized. Now, if you look at this meta-analysis, which they did for low-dose CT, you can see the other trials on there. However, the numbers in screening compared to the NLST was very small. It was 1,000 to 2,000 people in each of these trials. So while this too showed a mortality benefit, it was 5.7%. The overwhelming majority of data came from NLST, and hence this was a biased meta-analysis, but it still showed a mortality benefit. So let's look at the recommendations in the US. You can see across trials, across guidelines, the US and in Canada, where lung cancer screening is now part of the national protocol, all the guidelines ask for annual screening. So once a year screening is what's advocated. All the guidelines talk about screening between the age of 55 to 75. The number of pack years talked about is greater than 20 pack years, and they should be smokers or smokers. Ex-smokers should be within 10 years. So broadly, across the board, all recommendations talk about the same thing. Another question for you guys, what about false positives? So this is Margaret McCartney, who comes out with statements on the BMJ, and this is one such, says the reason most countries have hesitated to introduce lung cancer screening is the eye-wateringly high false positive rates. So Guy, what do you think? Is she right or is she wrong? Eye-wateringly high false positive rates is what she's talked about. There was a letter to the editor which came from David Baldwin, who has designed the Nelson trial, and he obviously said, no, it isn't. Let me show why David Baldwin thought that it was not correct. So NLST showed a 23% false positive rate. So out of 4 people who got screened, 25% were falsely positive because of the nodules. So a very high false positive rate, which is why Margaret McCartney talked about an eye-wateringly high number of false positive cases. But go down that list, look at Nelson, look at the look at the UKLS data, the United Kingdom lung screening data, and you see far smaller number of false positives. The reason they've got far lesser number of false positives is because these people had a group they called intermediate group. These were not regarded as low risk or high risk. They were regarded as intermediate. Intermediate would not count as false positive. They would get followed up at a year and then again 1 year later. And these 4 millimeter nodules or above, which looked benign, would only be followed up for 2 years and then come out of the trial. This would reduce the number of surgeries. It would reduce follow-up. It would reduce CT scan exposure. And hence, using this approach is probably a far better approach as compared to what was done with the National Lung Screening Trial. What's the problem? And this we'll talk about again when we talk about implementation in India. What are the issues with implementation of a cancer screening trial across the world, especially the developing world? The selection criteria we talked about, that's important. You select the wrong population, you get a lot of low-risk individuals, your lung cancer screening program is bound to fail. You need good quality CT protocols. You need to have good quality machines. You need to make sure that it's low-dose CT as opposed to the high-dose CT that we are used to do in patients with interstitial lung disease, for instance. There needs to be MDT available. There needs to be counseling available. The screening interval needs to be optimally defined. And smoking cessation needs to be incorporated into screening programs, because a lot of people, as I'll show you in a minute, actually give up smoking when they become a part of screening trials. And you need to get more people to participate. We've not done that well in the US and Canada with the screening trials. Far greater numbers participate in breast and colorectal as compared to what they do with the National Lung Cancer Screening Trial. And the false positives need to be minimized. These are quintiles looking at various screening strategies. And you can see right at the bottom, quintile 4 and 5, where if you screen 170 to 180, 160 to 170 people, you come up with 1 positive. So that's good screening technique as opposed to ones at the top, where screening needs to be done in far greater numbers. These are risk prediction models, and I'll finish in the next 2 minutes. So these are risk prediction models. And the one I want you to look at is the one which says the Tamemagi model. This is the PLCO ever smoker model. Large numbers, 50 to 74 years of age, BMI which is high, background of COPD emphysema, low levels of education, male sex are the defining factors. And this seems to be the most consistent population who would benefit from being screened. A little bit about volumetry of nodules, which is the standard now across Europe, not yet in the US. So 25% increase in volume is thought to be significant growth when you're doing CT surveillance. Remember, us in India and a lot of countries in the world look at the size of the nodule at the maximum diameter. This is looking at volume. 25% increase in volume seems to be a much greater measure. See the example at the bottom of that slide, 5 millimeter nodule. If you look at volume doubling rate, which is VDT, 5.4 millimeter size would mean a 30% increase, but that's not something you would manage to measure if you did maximum length or maximum diameter. So that's why volumetry is important. And I won't steal Nagarjuna's thunder, but just to show you that volume doubling time is what is looked at when you look at algorithms of screening today, rather than a measure of maximum diameter is what we did before. So I think I'll finish off now. I think I've spoken enough. Let me go to my concluding slides. So these are the algorithms that I'm sure Nagarjuna will speak about. A non-invasive approach or a minimally invasive approach is what we would advocate. The diagnosis and staging assessment would include a history, spirometry, and blood tests. The CT of the thorax, upper abdomen, and lower neck with IV contrast would give you a good amount of staging. And patient preference thereafter is what needs to be taken into consideration. Choose investigation which give maximum diagnostic and staging information with least risk. And here we have graded the patient according to whether they have a pleural lesion or a lung lesion, depending on which you do a pleural tap or a CT guided biopsy or one of the bronchoscopic techniques that Nagarjuna will talk about. When there's palliative intent, you would base your diagnostic algorithm on bronchoscopy, TBNA or EBUS. You can also do neck ultrasound guided FNA, and the PET CT forms the backbone in identifying lesions which have high uptake on a scan. What is new, what's different? So autofluorescence bronchoscopy is something that I wanted to mention. This is our narrowband imaging. This has been around for a while, but it's been thought to be too invasive for wide spectrum screening. However, patients who've got central lesions, patients where you're screening with high risk, autofluorescence bronchoscopy is something that's been incorporated into the diagnostic algorithm in the US. This is something which I found interesting, and there's a lot of literature around for this. This is canine scent detection in the diagnosis of lung cancer. So dogs, as you know, have a great sense of smell. and look and smelling seems to be something which is used as a screening tool today in Scandinavia. So I'm not joking, that's true. Scandinavia, canine scent detection is the way forward in lung cancer screening. And that's from Scandinavia. So you see a lab in the lab, a Labrador in the lab with the scent and diagnosing lung cancer. So those are my concluding remarks before I hand over to Nagarjuna. So identification for the right population for an individual country is of utmost importance. Trying to minimize false positive results is important. Trying to minimize procedures is of utmost importance. And choosing the least invasive one out of the ones which Nagarjuna will describe is very, very important. New techniques are available, but we need to amalgamate them into existing guidelines. And we'll talk about in the panel discussion as to how we do this in an Indian population. So I'm sorry I've shot over time by 5 minutes, but thank you so much for listening. And I'll now hand over to Dr. Nagarjuna Maturu. Nagarjuna, all yours.
Thank you so much, sir. I think it was an excellent talk on screening and the relevance, the way we have to look at it. So the next important thing for us to understand would be how to get a diagnosis. So in the next 20 minutes, I'll be talking on the tools we have in our country for diagnosis of early stage lung cancer. So once we screen a person, we're likely to pick up a lesion. So then how do we diagnose or confirm that it is actually malignancy? So what are the tools we have? So in the next 20 minutes, I'll start off by trying to define what exactly is an early lung cancer. Then we'll go on talking about the gadgets we have, a little bit about approach to how to choose a technique and when to biopsy a lung nodule. So the first thing is early lung cancer. This is what we are all talking about. The whole concept of screening is that we pick up lung cancer early in the course of the disease. So what exactly is early stage lung cancer? There's no exact definition for an early stage lung cancer. So the thing which is widely followed is the ISLC classification. So it doesn't talk about early stage or late stage. There are some groups which have defined stage 1, 2, and some 3A as early stage lung cancer. So what exactly is early lung cancer is basically if we diagnose a person early enough to warrant a surgical resection, his outcomes and survival will be better, and these are considered early lung cancers. As this graph says, this is the ISLC 8th classification. If you can see here, the survival is greatly dependent upon the stage of lung cancer. In stage 1A1, if you can see, the 5-year survival is 92%. It drops down to 53 when it is stage 2B. So if you diagnose somebody to have stage 1 or stage 2 lung cancer, then we are likely to give them a 5-year survival of at least 50%. So I would focus on this stage 1 and stage 2. So what exactly is stage 1 and stage 2 we have to understand. This might be a little bit complicated, but then we have to focus on this green and yellow boxes here. So people who have T1, T2 or N0, N1, these form what we call as an early lung cancer. Again, we should understand what exactly is this tumor staging. So T1 and T2. So T1 is lesions which are less than 3 centimeters in diameter and with no invasion. So they are basically intraparenchymal, no bronchial peripheral mediastinal invasion. T2 is 3 to 5 centimeters. They can invade the bronchus but don't come till the carina. So when we want to diagnose a person early enough to warrant a surgical resection, we should catch them in the early stages. That is before the lesion is more than 5 centimeters, before it comes till the carina, before it goes and invades the chest wall or the mediastinum. And the nodal staging also is important. N0 means no nodes, N1 is ipsilateral hilar, N2 is ipsilateral mediastinum. So I won't go into much details because this is there on the net. This is just to form a background. So we have to have a person with a smaller parenchymal lesion with only ipsilateral hilar, that is N1 nodes. You don't want to have N2 nodes. Now with this understanding of what exactly is early stage, then we should go on to look at the tools which we have for diagnosing this so-called early stage lung cancers. So the tool we have to use for diagnosing would obviously depend upon the lesion, the site where the lesion is there. So earlier, the central lung cancers were common, but nowadays there is a shift from central squamous to peripheral adeno. lung cancer. So when we have a central or an endobronchial lesion as the presenting feature, then obviously the diagnostic modality would be endobronchial biopsy. If you have a parenchymal nodule which is surrounded by lung parenchyma, then you have both the options. You can either choose a bronchoscopic approach or a transthoracic CT guided biopsy. If we have a lesion which is touching the pleura, obviously the choice of diagnosis would be a transthoracic ultrasound or CT guided biopsy. So endobronchial biopsy, this is a very small video. See, if you can see here, there is a lesion in the upper lobe, the right upper lobe. So this is very easy to diagnose because you're seeing the lesion. You take a bronchoscope, take a forceps, and then get a piece and then get away with it. So, but it is not always as simple as what is there in this video. So there are so many tools which help us make a reel better. So some of modifications to the conventional forceps biopsy are the hot forceps biopsy. If you have a lesion which is likely to bleed more, you can use an electrocautery guided biopsy. You also have cryoendobronchial biopsy, which is to get bigger pieces. You also have what is called a spur forceps. If the lesion is very tangential, you can use them. Then comes the newer advances in bronchoscopy, that is to improve the visualization. If you have a lesion as big as what I have shown in the video, it is very easy. But when we actually talk about screening, the lesions may not be as big as what I had shown, and they may not be as seemingly visible as what they are. So then you have all these newer advances in the optics. So you have the high definition bronchoscopes and you have non-white light bronchoscopy. This is what Dr. Raja Dhar sir was talking about. There are a lot of chromo endoscopies, that is the narrowband imaging, the eye scan technology, the autofluorescence bronchoscopy, and so on and so forth. So what these techniques do. So if you look at the optics, the white light bronchoscopy, every year the new bronchoscopes are being launched similar to our TV platforms. You have the HD video. Now we have the 4K bronchoscopes, which make the visions much better. And the newer technologies, which I won't go into much, basically help us by enhancing the visibility. This is one of the latest bronchoscopes which are there, the Olympus ones, where you have a lot of modes. The same tumor, we can see in a better texture. We can see the superficial vasculature by using the NBI mode. You can see the deeper vessels by using an RDI mode. And it will help us identify the site for biopsy. And when the lesion is not obvious also, by changes in the vasculature or changes in the texture, we can probably identify them better. There is some data to say that using this eye scan technology or these modern technologies can help increase the lesion pickup rate by a couple of percentage. However, they're not widely available, but then probably they'll come into the market. Then coming to the focus is the lung nodule. So when we do this low dose CTs, as was being talked about in the screening programs, we end up picking up what we call as incidental lung nodule, peripheral nodule. So when we have an incidentally picked lung nodule, which is either screening for lung cancer, in India, what happens is you get screened for pre-occupation checkup, or you get screened because you get COVID. So in fact, actually, I would say COVID has served as a sort of a screening program in our country. We've ended up seeing a lot of incidentally picked lung nodules. So the 4 questions which we have to ask are whether we actually have to biopsy these nodules. Second, if we decide to biopsy, how to biopsy these nodules. And then if the lung cancer is confirmed, then how to stage the mediastinum. And once you have the T and the N stages, then you have to decide the treatment plan. So the first question is whether we have to biopsy every nodule which is picked up. So this is not exactly yes. So you have several societies which have given recommendations on how to determine which nodule is to be biopsied. One of the widely practiced guidelines is the Fleishner Society's recommendations. It has been upgraded and the latest is 2017. So you have separate recommendations for solid, subsolid and a non-solid nodule. But for lack of time and for interest in the Indian context, we'll talk more about solid nodules. So if you have a solid nodule, which is less than 6 millimeters, which is picked up, and then the person is low risk. So basically you have 2 things. You look at CT size and you look at the risk profile of a patient. So how to stratify a person as low risk or high risk? Again, there are several algorithms. You can choose any one of them. So basically a high risk person would be somebody who's elderly, who's a smoker, who either has a past history of malignancy with an upper lobe lesion and certain characteristics of the nodule like stipulated lesions. So if a person falls under low risk, less than 6 mm, you actually don't have to do anything, no follow-up also. If it is high risk, then just one follow-up CT at 12 months. 6 to 8, you just have to do a follow-up, no need to biopsy. So the biopsy is actually recommended if the nodule is more than 8 millimeters. If it is more than 8 millimeters, again, it is not that every nodule has to be biopsied. Again, you look at the risk profile of the person and then decide accordingly. So this is the Asian recommendation which has been published in the chest a couple of years ago. So when we have a person who has a nodule which is more than 8 mm, which is picked up on CT screening, the first thing is to refer to a center which has expertise in dealing such nodules. Then you determine the clinical probability of malignancy. If the probability is low, then you only do CT surveillance. You don't do biopsy and then you see whether the nodule is increasing or not. If it is moderate risk or a high risk, then you have several options. You either do a PET scan to look at whether it is a hypermetabolic or not, or you can go ahead and do a non-surgical biopsy, or you can directly do a surgical biopsy. This again would depend on several parameters, which I'll be talking about in a couple of slides. So now talking about now that we have decided which nodule to biopsy. So when we decide to biopsy a nodule, again, the next question is which modality should we use? So you have a CT gated approach, or you can do a bronchoscopic approach. For a nodule, something like this, we can probably decide between a CT gated biopsy definitely has a diagnostic yield which is little higher than what a bronchoscopic biopsy can get, but it comes with its own set of problems. So it has a higher rate of pneumothorax and a higher rate of bleeding. A bronchoscopic biopsy, on the other hand, as a pulmonologist, which we are more interested in, is to have a bronchoscopic approach. So bronchoscopic approach is evolving over the years. So the introduction of radial EBUS has actually marked a new era in the bronchoscopic approach to peripheral pulmonary lesions. So pre-radial EBUS, before 2002, we only had the conventional bronchoscopy. And with this, majority of the nodules were not visible. So what happened was the yield of a normal bronchoscopy was pathetic. It was only to the extent of 20 or 25%. So to the extent that it was recommended that conventional bronchoscopy alone should not be used for diagnosing a peripheral pulmonary nodule. With the advent of radial EBUS, the scenario has changed. The yield of a bronchoscopic approach has increased. And then we have a lot of studies, and the meta-analysis has said that the yield has increased from around 25 to 70%. But still it is only 70%. 30% we still do not diagnose. What is important is the complication rate has come down from 15% to 2.8%. So this is a very important advantage of a bronchoscopic biopsy. So when we have a nodule which we decide to biopsy through the bronchoscopy, there are three important steps. First is to identify the path. So as we go distal, the number of branching of the airways increases, and it is important for us to have a proper navigational plan. This is called navigating to the lesion. So for this, you have several options. You can use a CT and create a map if you have a good quality CT. You have virtual bronchoscopic navigation, which is there in our country and which we do. So I'll be talking about it. There are some things which we don't have, that is electromagnetic navigation or the robotic bronchoscopy. Once you reach to that nodule, then you have to see the nodule. To see the nodule, this is where the radial EBUS comes into picture. And then you can also use a CR to see the lesion. Then the cone beam CT, which is not there in our country, probably might be coming to our country soon. These are the ways by which you see whether you reach the nodule or not. So you navigate to the nodule, you see the nodule, and then you sample the nodule. So you do brushing, you do biopsy, you can do a BAL, you can do a cryobiopsy. There are several ways to sample that nodule once you reach the nodule. So the basic backbone for a bronchoscopic approach to a peripheral pulmonary nodule is the radial EBUS. So we'll talk a little bit about radial EBUS. So radial EBUS initially was available only with Olympus, then the Fuji also has it. The Pentax is also planning to launch it. Radial EBUS has now become a part of the routine bronchoscopy. So you have an ultrasound processor, you have a probe driving unit, and then you have the radial probe ultrasound. This is the radial probe. So you have a probe with an ultrasound at its tip, which is revolving. So when the probe is in the bronchoscope, whatever is surrounding the radial probe will be seen in the ultrasound screen. And then you have this set, you have a guide sheet kit, you have a brush, and you have a biopsy forceps. So briefly to explain the procedure in a minute. So basically you have a guide sheet. Through the guide sheet, the radiolibus probe is passed, and then you start searching for the nodule. Once your radiolibus is within the nodule, the probe, then you see the nodule, and then you fix the sheath there. You fix the sheath, then you remove the radiolibus, the probe, the ultrasound probe. The sheath is now exactly at the entrance of the nodule. So then through this sheath, you pass the brush, forceps, ball, and everything you do. So that basically you're doing sampling of this nodule. What we have to understand in radiolibus is that there is no real-time visualization. So you see the nodule, then you take out the radiolibus probe, and then you do brushing and biopsy sort of blindly, presuming that the guide sheet is in the same position as where you have left it. So this is a schematic picture. So what you can see here, the probe is now in the center of the nodule, as you can see on the radiolibus ultrasound image. So once it is there, the probe is removed, the sheath is left there, and then you can see the brush which has come in and went away, and then the forceps is coming in and the biopsy is being taken. So this is how a radiolibus is performed. And then how does the image look? A normal lung is called as a snowstorm appearance. A ground glass lesion will have what we call as a blizzard sign, and a subsolid or a consolidation pattern will have what we call as a mixed blizzard sign. What is more relevant for us is the solid nodules, which will look as these hypoechoic structures on the ultrasound screen. If the radiolibus probe is in the center of the lesion, then you get what we call as a concentric image. If you are on the side of the lesion like this, then you get an eccentric image or an adjacent image like this. Now, if you have a concentric image like this, then the yield of radiolibus will be 80%. Whereas if you have an eccentric image, the yield falls down to roughly around 50%. So how do you improve your yield on radiolibus? By choosing wisely. So if you have a CT which has what we call as a bronchus sign like this, then the yield of radiolibus will be better. Bigger the size, better the yield of radiolibus. Solid nodules, better the yield as compared to ground glass nodules. Location, the more distal the lesion is, the more peripheral the lesion is, the more difficult it is for the radiolibus to go there. And then lastly, as I have said, if you get a concentric image, the yield will be better. So now we have the radiolibus, which has improved our yield from 30% to 60 to 70%. Now, how can we make things even better? So at every step, you have tools to help us improve the yield further. So step one is navigation to the lesion. So a radiolibus won't help us navigate, reach the lesion. It will only help us visualize the lesion. So you have what we call as navigational platforms, navigational bronchoscopy, which will give us the path. I'll be talking about this in the next slide. Then step two is visualizing the lesion. So radiolibus will show us the lesion, but it is not real time. So how can we make it real time? By adding a fluoro to it, so that you exactly know where the radiolibus probe was, and then you can direct the brushing and the biopsy in the same plane. Or you can get cone beam CT in the future, where you can actually do a CT and then see whether you're within the nodule or not. Then step three is sampling the lesion. If you have a biopsy, you will get a smaller forceps biopsy, will get a smaller piece. So now cryo is coming in. We are doing cryo biopsy for peripheral lesions to get bigger pieces. And then lastly, addition of rapid onset evaluation. So next is a little bit about navigational tools. In India, we only have one navigational tool, that is the lung point or the virtual bronchoscopic navigation. So basically, it is a computer guided algorithm where the CT is loaded. It will give us a path, and then the path will be run simultaneously with the real-time bronchoscopy. As you can see here, on the right side is the virtual bronchoscopic path, and on the left side is the real-time bronchoscopy happening. So both are synchronized, and then you can see the blue line which is there. It will show us into which bronchus we have to go, and then eventually it will lead us to the exact lesion where it is there. So this is one of the, which you can see, this is the nodule. So once you go there, once you reach that particular bronchus where you are, then you use the radiolibus to confirm that you have reached the site. So the same thing. So now you have reached the particular site using the navigation. Then you do the radiolibus, you see the lesion. So this is one of our cases, a 69-year-old male. diabetes, depression, who was incidentally picked up to have a lung nodule on a screening CT, a general health checkup. So this is the nodule which is there here. So this is how a nodule might look on a screening load of CT. So in this particular case, we bronchoscopic navigation, and you can see the path how it is being shown. It is going into the right upper lobe, anterior segment, posterior subsegment, inferior subsegment, and so on. And this is the lesion. So with this, we have done the radial EBUS. There you can see the lesion exactly, concentric image. And then to make it real time, we also added a fluoro and then did a biopsy. And lo and behold, it was not actually malignancy, it was tuberculosis. So this is what is very important in our country. Majority of nodules might actually be becoming non-malignant benign nodules. So this is what we have in our country. So the future is even more exciting. So what we can do till now is to go through the bronchoscope, through the airways. Now Archimedes is the new thing where bronchoscopic transparenchymal nodule access, where you actually puncture the bronchos, go through the lung parenchyma and get a biopsy from a nodule which doesn't have access to the bronchial tree. Then the cone beam CT, as I have said, will further improve the diagnosis by helping us know whether we're exactly within the nodule or not. Robotic bronchoscopy is another exciting tool which is there, which also gives us the path and helps us play with the bronchoscope. So these are all things which are probably going to be launched in our country in the next couple of years. But then how to choose whether to go for a CT grade biopsy or a bronchoscopic biopsy? There are several studies which looked at it. Meta-analysis has been done. The yield is definitely still better with CT grade biopsies, but with a higher complication rate. So what are the advantages of bronchoscopic sampling? I'll just spend 1 minute here. Definitely lesser pneumothorax, better control of bleed if it happens. Third is very important. You can simultaneously do a BAL when we do bronchoscopic approach, and this is very important when we have a lot of benign nodules or infective nodules. Simultaneous mediastinal staging can be formed. This is again important. If you pick up an early stage lung cancer and radial EBUS, the same sitting, you also do a linear EBUS and finish with the mediastinal staging also. And then in lesions which are difficult to be accessed by CT grade biopsy, central lesions, emphysematous lung, then you can definitely go for a bronchoscopic approach. And last, another interesting thing is no tract seeding by malignancy. This is something which we never think about, but there is a meta-analysis which says that in stage 1 lung cancer, if you do a CT grade biopsy, the hazard risk, the hazard ratio of a pleural recurrence is 2.58. So this is something which we have to think before we start doing CT grade biopsies left, right, and center. So how to choose a correct modality depends on several things. The location and the CT characteristics of lesions, availability of tools, and the expertise of the person who is there at that particular center, the physician preference, patient preference, and the fitness of the person to tolerate sedation anesthesia. This is also very important. Bronchoscopic biopsies need some amount of sedation. And last but not the least in India is the financial considerations. This we will talk about in the panel discussion also. So once we have diagnosed a person to have a lung nodule which is malignant, the next thing is to do the staging mediastinoscopy. So EBUS is now considered for staging the mediastinum. I'll just quickly run through the slides because every one of us know about EBUS. It has the highest diagnostic yield. Only 2 questions, which are 2 misconceptions which we have. Do we actually have to sample the mediastinum if the PET scan shows it to be FDG avid lymph node? This is one such case where we have peripheral lesion here. Definitely it is touching the pleura. So CT grade biopsy was done, confirmed it to be adenocarcinoma. PET scan showed an SUV of 4.5 in the subcarinal and a right hilar showing SUV of 4. So we went ahead and done an EBUS, and then it has come out actually as a reactive node. So every PET positive node is not actually malignancy. It has to be sampled. Second, if these nodes are not there on a PET scan, can we just presume that it is not there? Again, there is a lot of data to say that even if the PET scan or CT scan doesn't pick up N2 nodes, doing an EBUS plus EUS will pick up occult N2, N3 disease, and the NNT is only 14. So again, when we have a person who has a radiologically negative mediastinum, if the person has a central tumor or large tumor, then definitely EBUS has to be done to confirm this stage of the mediastinum. I think with this, we will conclude this part, and then I will skip these things for the lack of time. And to summarize my talk, it is important to say that the scenario is changing. 5 years back and now we are in a completely different zone. You have a lot of gadgets, tools with us to safely biopsy the nodules which are there anywhere in the thoracic cavity. The only important thing is we have to choose the gadget wisely. And most important, whenever we do any intervention, is to always ensure safety of the patient and safety of our scope. I think with this, I will end my talk and then we can have the panel discussion. Thank you so much.
Thank you very much, Nagarjuna. Lovely talk as always. Really appreciate the efforts that you put in making things lucid for all of us. So we'll go to the panel. Just a quick thank you to Dr. Ravi Dosi and Dr. Vijay Chennamchetty, who actually got us together. We discussed the panel before we started. So thank you guys. And of course, to my good friend, Dr. H.N. Krishna, for conceiving all this and supporting us through the CCI endeavors. So let me start off and get Anuradha into the discussion. Anuradha, what do you think about screening of lung cancers in India? Do you think this is something that is achievable in the future? Do you think there are challenges which are difficult to surmount as things are today? And if they are, what are the challenges that you perceive as being important or the most important in today's scenario?
So, sir, definitely achievable, yes. We're all optimistic. But there are definite, many challenges which are there before we start with this program in India. First of all, I would like to say that the programs could be centralized, or it can be at the peripheral level, or it can be hybrid one also. And we have advantages and disadvantages at all the levels. The most important factor which I would consider to be challenging in India would be absence of a coordinated, comprehensive healthcare system, which is the lacking in India. So therefore, the standardization of the diagnostic modalities and further the whole program is lacking in India. The technical capabilities, the communication and the data system is also on the little lower part. So I would feel, and along with that, the incidence of TB, the prevalence of TB that we have, the granulomatous conditions that we have, which we pick up incidentally on chest x-rays or CT scan, which is higher in India and our developing countries, is also, it poses a challenge to us, because to differentiate between both the malignant or the non-malignant lesions becomes important for countries like India. So I feel definitely there is a challenge, but there is a way to go about it.
Problems we have across the country is balance or lack of balance between the private and government healthcare systems.
Raja, the voice seems to.
You guys hear me? Yeah.
If you can just repeat the question.
Can you guys hear me now? Is that better?
Now it's
I will do.
Better.
I will do. Little better? Yeah.
Yes.
So sorry, Anuradha, I know you guys lost.
Again, I think
Dr. Raja Dhar must be logging in from a different this thing. At the same time, adding on to what you had said, countries with much larger populations also have successfully rolled out the screening programs. So having had looked into the China's program, I think China is a much larger population and is doing this lung cancer screening regularly. And I think the difference between the two countries is the infrastructure capabilities, and as Dr. Raja was telling, the upgradation of the government setups also. So a lot of thing is funded by the government there, and most of the government setups have the technique and the infrastructure, which is much better than any of us in India have.
I would like to add to the screening process. One is the literacy rate of the patient with respect to the condition should be encouraged. And the resources, we do diagnose sometime, but the patient where we need to send, it's far away from this native. And the patient, because of that, it doesn't reach the desired place. Second, the financial constraint. And in India, we have seen that many national programs have been successful if the patient is getting any monetary benefit out of it.
Sure.
So
Kamaljeet, I was coming to this, and I'll sort of ask Anuradha and then come straight to you. You know, there's a few of us here. You belong to an army hospital. There's a couple of us, Nagarjuna and myself, who work in the private or corporate sector. And then there's Kamaljeet, who works in the government sector. So do you think this is a challenge? And if this is a challenge, how do you think this is surmountable? You guys have a system where I think a screening program wouldn't be difficult to run in an army setup. For a government versus private, people paying out of pocket, government funding a particular project, how do you think we'll balance this out? If you had to roll out a program, Anuradha, for the country tomorrow, how do you think, just from a health sector point of view, how do you think it's possible?
Definitely a sector like us, where we have more of a organized sort of setup, which is more structured, and a comprehensive healthcare system, if we call it. We have a niche, a small community where everything is all taken care of. It'll be much better to have the program rolling here. The challenges that I feel we will have is again, because our setup has various statures. Like you have your central hospital, which are tertiary care hospital. You have the peripheral hospitals, which are present in the peripheries of India, where only minimal sort of investigations and further tools are available. So this will be one thing which I would feel, but that can add to the advantage also, because you can have these people's told about the various program that you want to run, and then the whole of the periphery can come and refer the patients to you. So this is one thing which can be there. And second, if we talk about the rolling of the program, definitely making a algorithm, first of all, depending on the eligibility of the people, that who all are eligible in this, and what all the infrastructures and all which would be needed in this, and the plan further ahead of having a shared discussion between the patients, because not only the diagnosis is important, but also the patient's willingness to undergo various treatment or the further diagnostic or the further follow-up is also required. And they need to be fully aware of the harmful effects of the screening also.
Sure. Great, Anuradha. So I think if you think about the analogy with breast cancer screening in India, I think that's a good way of going about it. We have definite guidance, and we have been told who we can offer mammograms to, which population, what age, and then you leave it to the particular health sector from which the patient is seeking help, is seeking care, to do it the way they would do it. I don't think we have actually reached the stage where we can roll out a program which is government funded for lung cancer screening. And I think I completely agree with your thoughts, Anuradha. For something like the army hospitals, that's something which is doable. For the government or the private sector, as things stand today, probably having a guideline or a protocol, having a discussion with the individual high-risk patients and offering it to them. And then depending on whether it's private or government, the funding depends on the individual or the government who goes ahead and does the screening. So I think that's probably our collective intellect about how you would roll out a program. I'll come to you, Kamaljeet, and we'll talk about so the next 5 minutes, we'll try and spend in defining a population for our audience today. Who do we screen and how do we screen? But even before that, there's something that Anuradha spoke about, which was about the presence of lots of solitary pulmonary nodules. Even Nagarjuna, when he did his talk, talked about the COVID pandemic and the huge number of cities that we did, and an involuntary screening program, which he sort of very appropriately defined, I think. So we had this huge number of cities where we have picked up solitary pulmonary nodules and we don't know what to do with them. So how do you think the presence of these nodules on a CT is going to impact our population as compared to what we saw in the National Lung Cancer Screening Trial in the US or the UKLS, the United Kingdom Lung Cancer Screening, or Nelson? How do you think ours will be different? And how do we go about circumventing the problem which all of us talked about, which is finding far more solitary pulmonary nodules as compared to what they find in the West?
So, the Indian population is around roughly 140 crores, and the incidence is around 6.9% of the lung malignancies in this. And if you take about 6.9% of incidence among the 140 crores, this comes to around, I'm not that good at mathematics, but yeah, still maybe around
8.5 crores.
Yeah,
8.5
crores.
Correct.
And in those 8.5 crores, if you go with, it was like shown in the NLST, National Lung Screening programs. So these out of those, we need to see how many these smokers, the biomass fuel exposure, the patients who are exposed to the environmental pollutions.
Sure.
They need to be screened well. And first, once suppose if the nodule is there, if you have if the screening is done and there is you have got the nodules, and the patient has to be well informed about it. Second thing is now rest. It depends on the patient compliance first of all. How much the patient will follow to you once you have told the patient about the nodule. Second thing is, once you tell the patient that about the malignancy, yes, you got, there is some chances of a malignant condition within you. Second thing is the patient is deterrent to it. They really, they'll seek the alternative medicines advices, and they'll waste their time over there. And sometimes when they come to you, it's only on the stage 4 and stage 3, at the stage 3. And in the national screening programs, I think there should be a proper SOPs for there's no proper SOP in anywhere in the country where yes, the patient has been scanned, like we have in tuberculosis examination programs, like we have other national programs. There is no proper overall SOPs for way of improving the screening with respect to the malignancy in the patients.
Sure. So thank you, Kamaljeet. I agree with all your points. I think what you have said holds true. The fact that there'll be a very large population that needs to be screened, and the fact that we need to define this population and try and make sure that we are only going for the high risk ones. And then once we have defined that population and screened these individuals, we need to have a free and frank discussion with these individuals to say how we go forward in monitoring these individuals in the long term. So let me come to you, Nagarjuna, and I'll come to Anuradha after that. So if you think about NLST, there was about 23% of people who had a nodule, and these were false positives. So 1 out of 4. From what all of us have said, you have said, Kamal has said, Anuradha has said, the numbers are likely to be greater in our country. You also defined the nature of the nodules very nicely when you spoke about the follow-up of solitary pulmonary nodules. You spoke about the size of the nodules, about whether they are more of ground glass or they are sort of semi-solid or solid nodules, the rate of increase of the nodules, etc. So how would you translate this? Not the entire algorithm, but the sort of basic outline. How would you translate this into more Indian terms? And how would you actually chalk out a plan for lung cancer screening in these individuals? The population we'll define in a minute, but more about false positives and how to circumvent this problem is what I'm asking you, Nagarjuna.
Definitely, so if we start screening people, then we're likely to pick up more nodules. The ones which we all talk about is the post-infective, post-tubercular nodules which are there. So I think one extra question which we'll have to fit in our history taking is, do you have a past history of TB or not? I think that will help us to some extent. And also, I think if we carefully look at the CT picture, then we can easily make out whether it is a post-tubercular nodule or it is not. Because usually you end up seeing telltale signs of fibrosis, some scarring and all those things. So I think we can avoid doing a lot of biopsies. In fact, we also avoid a lot just by looking at the clinical context. If a person who has a past history of a TB, who has a upper lobe, a nodule which is fibrotic with scars all around it and not much symptoms actually, then we end up just saying that it is definitely a post-infective and don't have to biopsy. So definitely we're going to pick up more nodules, but then it is up to the clinician to decide whether to actually start poking into all of these. So if we look into the clinical context as a whole, definitely we can avoid all those false positive rates. 1. 2 is start biopsying every nodule. Again, that is not always practical or feasible. 8 mm still a very small size, I would say. So from our experience, the size at which a biopsy becomes easier is probably 1.5 to 2 centimeters. So if it is lesser than 2, then definitely it is a challenge even in the best of centers, and the yield is dramatically less. So if you decide on sampling all these smaller nodules, then it is going to be tough unless actually you have the expertise training and doing all those things. So in India, probably if you pick up a nodule which is around 8 mm or 9 mm, and then you're not very sure you can reach it, the other alternative way is to keep them under observation, repeat the scans, and then see whether they're actually doubling or not. So that is another way to go about it. You assess your pre-biopsy feasibility, whether you'll be actually able to reach it, target it or not. But if it reaches 1.5 or more, definitely yes, we should think about sampling these nodules.
Sure. So great thoughts, Nagarjuna. Let me put that in perspective. So for the audience, I think what we are saying here is that, like Nelson, you probably need to have 3 categories here. You need to have the low risk category, you need to have the intermediate category, and you need to have the high risk category. In the intermediate category, you will have all the radiology pictures that Nagarjuna spoke about just now, which is patients who have a more fibrotic looking solitary pulmonary nodule. You have a bit of calcium within it at the center, which shows that it's long-standing. The history of TB that he talked about is relevant. And even if they're above 8 millimeters, and if these telltale signs of past history of TB is present, you would probably screen them in Nelson. Screen them like Nelson for about 1 to 2 years, and then you would leave them if they are not increasing by the 30% volume that's laid out. So I think the screening protocol remains the same. The sizes that Nagarjuna talked about remains the same, but you have this intermediate category where these granulomas get classed. They have a shorter follow-up. They don't have a long-term follow-up. You tell the patient to be absolutely certain before we go on into poking needles that Nagarjuna spoke about in these lesions, and we'll follow them up long-term. So that's about follow-up of nodules and the challenges that we have about granulomas and overcoming them. I'm coming to you, Anuradha. So your comment, and along with that, let's now spend the next 2 or 3 minutes trying to define a population which we think is appropriate in our country, the so-called high-risk individuals we would want to actually screen in this country. So first your comment, and then we'll sort of put our collective heads in defining a population for our audience who might benefit from screening. All yours.
Regarding this pulmonary nodules that we are talking about, I agree with Nagarjuna completely. Along with that, I seriously feel that there is importance of talking it out to the patient. So one thing that I feel that some of the patients do have these competing kind of ineligibilities for surgeries or for further investigations. These are very important. They look very simple, but I think if a person has already had severe sort of obstruction on the spirometry and all, you wouldn't want to do any further kind of investigation. So pre-evaluation is also must, and a discussion with the patient and the relatives probably here in our Indian scenario, where how much do they want the investigation to proceed. What we talk about is an ideal situation where if the program is forced on to the people, which is not what happens in India. So I feel that will become one of the most deterrent thing probably in our societies.
So another point well taken. I'll come to the sort of selection of population, but I think we have said that we have to give the Indian population a choice. We do that in all screening programs in this country. And probably if this person has such a poor performance status, even if they qualify, they wouldn't get into the screening program in the first place.
Yeah.
You know, you would counsel them against having routine CTs to try and pick up nodules because you think you wouldn't be able to do very much about them even if you pick them up. So that's something which is very relevant that you said, which is important to remember. Population now, Anuradha.
So population, if we go as per the various trials that the past has given us evidence on, so I feel age group of 50 to 75. So basically what we have to consider is, first of all, the eligibility as per the age groups. We're talking about the whole of the program, sir, if I'm correct with that?
Yes. So we're talking about the entire program, and we are trying to sort of sieve out a small section of the population who would be the most appropriate or the highest risk to go into the screening program in our country, whom we would offer screening to. That's what we're talking about. Yeah.
So the first thing goes to the age, which I feel as most of the trials are within 50 to 75 years old age, that looks plausible. So this looks logical. And the second is definitely a smoking history. One of the study took 30 pack years, the other one took less than 15 also. So we can take an average out of 20 maybe. So that is another second thing. The third thing is again leaving the cessation of the smoking. If it is within 15 years, that is one thing that is a good criteria. And also that we spoke about, Kamaljeet also spoke about the high-risk factors. So in case we find that few of the high-risk factors like biomass exposures and the second-hand smoking and the air pollution, they show a risk factor of more than 1.5% as the CHEST, one of the CHEST 2018 guidelines and expert panel had said. So probably that can also become one of the qualifying features of the eligibility.
Sure.
So these are
Great
my
thoughts.
input.
Great thoughts, Anuradha. Let me sort of quickly go to Kamal and then to Nagarjuna, and then I'll come back to this question and we'll try and weave something together for the audience. Kamal, anything to add to what Anuradha said?
Yes, sir. Like as the ma'am said, a specific target population, but I feel like smoking is prevalent and people are maybe we can think of around age group between 35 to 60. They should be well, because if we talk of early screening, naturally the age group has to be lower down so that the younger ones, which because recently I have seen that even as younger as age of 20, I have seen recently I got one patient came to OPD with just complaint of chest pain, and we got this. There was a small opacity on the radiograph, and then we got the CT done. It turned out to be hepatotic etiology. So we should never hesitate in getting the investigation, which is CT. Sometimes, as I said, if due to financial constraint, they might oppose, but you need to explain very well to the best of your knowledge to the patient so that they should get it done. As I said, between 30 to 60 age group is the most feasible. Yes, we can lower down the age group as per the X-ray reading.
Sure. So quick question. They go to Nagarjuna next, Kamaljeet. So why 60 though? I understand why you're lowering the age. Why have you cut down the age to 60? Why not a person who's 65 or a person who's 70? Why would they not be screened if they are in the high-risk population?
Is it to me, sir? To Dr. Nagarjuna?
No, I asked you, Kamal, but yeah, we'll. Any thoughts? Why not someone who's 65 or 70? Why would you exclude them from the ambit of screening? I understand the lower age group, Kamal, but why not 65 or 70?
Yes, as Dr. Nagarjuna and ma'am also have said that they might have been predisposed conditions like Dr. Nagarjuna well explained before. They would have had history of previous tuberculosis with a lot of calcifications over there, and that might they might mimic the they might mimic the pulmonary nodules. And as Dr. Nagarjuna said, that over investigation of the patient that need to be taken in mind. So.
Okay. Okay.
One thing I want to add here, so just a small thing, that the moment we broaden the criteria for intake, because we are talking about the lung screening. Sure. We're not talking about diagnosing a cancer in a high risk. We're talking about lung screening which is at a broader aspect. The moment we broaden the criteria, you have to screen more number of patients to get one diagnosis.
Agreed.
So like
Agreed,
1 in
Anuradha.
320. So
Agreed.
that is why I thought.
Sure. Agreed. Nagarjuna.
I was
Your
just thinking of saying the same thing as what Dr. Anuradha Madam has said. I think Dr. Kamal is not wrong in saying that once in a while we come across one person with malignancy, but the concept of choosing a target population is that you want to pick up as many as possible.
Sure.
This particular reason, we should not lower the target age to 30. 30 is, I'll feel it's too less. I think we should stick to somewhere between 50 and 75 or whatever it is. So that is where the chance of picking up a malignancy or a nodule will be more. So identifying the risk, definitely smoking still remains the strongest risk factor. So the predominant thing to choose will be based upon smoking history, smoking index, the years since stopping. All of these are numbers which we can choose, but then the bulk will be smokers. Smokers in any form, because still the rural India has a lot of indigenous forms of tobacco. So it need not be cigarette, it can be BD, it can be whatever form of tobacco smoking. Biomass and other forms of things which are definitely a risk, but I don't know, there's still the magnitude of risk for lung cancer, I would feel is lesser than that in smoking. So to make it simple, I think it should be limited to smokers, 50 to 75 years. Number of packets cut off, we can 15 or 20. It is, I think it is up to us. It cannot be one number, but then 15 probably is good enough.
Sure. All fair points. Let me try and put these thoughts into perspective, and quickly, if anyone has a comment and differs with me, please add that comment in. But we need to move on also to other thoughts that I extent agree with Kamaljeet. I think probably an age younger than 40 is important, and I'll tell you why that is. So if you look at the age of diagnosis of COPD in our country, we have lowered it down to 35, and going forward, we'll probably roll it down to 30. And the reason is what both Nagarjuna, you and Anuradha have spoken about. It's exposure to air pollution, it's exposure to biomass. So it will be well nigh impossible to actually recruit patients. There is high air pollution, because then you're recruiting all of India. There would be hardly anyone who's not exposed to air pollution in the urban cities that we live in. Biomass in the rural areas, it's almost everyone. I mean, biomass exposure is 3 times the smoking hazard in the developing world. So it's a huge number. It's 3 billion people throughout the world. A significant amount comes from India. So I think somewhere around 40 is fair in this country. You lower the age from 55, which is the international recommendation, to somewhere around 40 to 45. I think that's fair. I think you will never be able to pick up biomass or air pollution in screening, like Nagarjuna said. Even though you should be able to, it's not measurable, which makes it difficult. I think it's important to have a smoking history, and 30-pack years or ex-smoker 30-pack years having stopped smoking within the last 10 years should be coming into the screening ambit. And I think COPD, as we know, is an independent risk factor. Emphysema is an important independent risk factor. And if you have these, then you should definitely come into the screening program, irrespective of the age of the individual. So that's my thinking. One thing to add to what you said, Anuradha, fair point. As soon as you widen, the number needed to treat increases to pick up one lung cancer. However, here we are not doing it the way the UK and US are doing it. We are doing it as in offering it to the patient, which immediately will lower numbers. You know, and I know that in our country, if you ask 10 people to come into a lung cancer screening program, probably only one would agree. The rest would deny it. So numbers would automatically go down. Even if you widen your net, it's only going to be a small number of people who come into the screening program, in my thoughts. So those my pouring in. Unless anyone has anything to add in this, we shall move on. Anything, guys? Okay, so we'll move on. I wanted to ask you about the procedures. I'll come to you with this, Nagarjuna, because you are our interventional expert. So the intervention centers doing intervention in this country, and the number of people who have access to thoracic surgeons in this country are few and far between, as you know. It probably represents less than 1% of the Indian population when you look at either of these. So do you think with such limited access, we can roll out a program where we don't have access to these modern investigational tools and the treatment tools that we would need in case we needed to treat once we detected early lung cancer?
No, I think this would be the strongest deterrent to any screening program in our country. So if you look at the number of centers which have access, I think CT-guided biopsy is something feasible everywhere. And that is, in fact, even today, the most widely used modality for sampling any nodule. So that is there. But then the smaller the nodule, it is even difficult for the transthoracic approach also. So the bronchoscopic approach, it is slowly getting into the market. The radial EBUS, the number of centers having radial EBUS is slowly increasing. So not only it is the availability, the expertise of the person. Radial EBUS also has a learning curve. So it takes at least 50 to 100 procedures for the yield of radial EBUS to start from 50% to go to 70-75%. So at this juncture, I would say the number of centers which are doing radial EBUS actively is still in double digits. And these centers are in the private setup where it is charged. The corporates won't do it for free. So the financials again come into the picture. And then once you diagnose a person to have malignancy on radial EBUS, then comes a series of investigations. You have to do a PET scan, you have to do a staging EBUS, then you have to do a surgical procedure. So all of these would require cost, again availability of the scanning, then lastly competent thoracic surgeons who are able to do it without problems. So I think every step we have a lacuna.
So that's another learning area, isn't it, Nagarjuna, for all of us? I think we need to start up training programs in this country, training programs which are not limited to the corporate or the private sector, but is a private-public partnership, engaging doctors from the army, doctors like Anuradha, etc. And we have one structure where we have access to management once we detect early lung cancer. That's what is lacking. We have come up with DNB thoracic surgery. That needs to be more widespread. We need to have not cardiac surgeons, but not cardiothoracic surgeons, but thoracic surgeons who do only thoracic surgery if we are to win this battle in early lung cancer detection. I think that's a very important point that comes across.
One positive note also. So we always say that we are not good, but then we are much better than what we were 5 years ago.
Sure, Nagarjuna, fair point.
But I think another 5 years, we will be in an even better position.
Much better.
Because
so Nagarjuna, fair point. I like your optimism. I like Anuradha's optimism. The challenge is what Kamaljeet spoke about a little while ago. You know, we are a country of 140 crores. And if there are 6.7, as you quoted, which came to be something like 8.5 crores, the graph is probably going up like this, Nagarjuna. It needs to go up like this. And we need to be we need to join hands. So this is not a negative comment against the country. This is just to say that we need to get our act together and we need to train our young pulmonologists much more proactively in doing these procedures going forward. And we need to procure equipment. The equipment needs to be cheaper. We need to have access to good technicians and need to get our acts together and do this quickly. Otherwise, we lag behind the rest of the world, even though we have the talent to do it.
So I think there is a flip. Sorry, Nagarjuna, I'll just add in a little bit. There's a flip side to this investigational approach also, sir. There are many places. So we make a algorithm. Suppose we make algorithm. I say ki less than 8 mm of nodule not to be touched. So there'll be many people in the periphery, in the community setup where they would have that itch to send it for CT guided or do it, which is actually again overdiagnosis and leads to more of psychological trauma and blah, blah. A lot of other harmful effects are also there because of basically investigating, because to put it into the heads of people, the whole of algorithm would be a little difficult in that.
Difficult, but like you said, Anuradha, not impossible.
Not impossible.
It's a challenge with all diseases that we have. But so it's something we need to live with. Let me come to Kamaljeet with a question about PET CT. So short answer, Kamaljeet, if that's okay. So if you saw the algorithm that I showed briefly, I'm sorry, I went through the slide quickly, and so did Nagarjuna when he spoke about PET CT. But if you look at the management protocol, there's a lot that includes PET CT. And there are two challenges with PET CT. One is access. PET CT centers are also not huge, especially in tier 2 and tier 3 cities, let alone rural areas. And the second is that the granulomas that we talked about again would have high uptake even on a PET CT scan. So how would you position PET CT in our algorithm, in the Indian algorithm, when you're investigating for early lung cancer detection?
So granulomas, sometimes they are associated with the malignancy, like you have in disease of sarcoidosis and infections like mycobacterium tuberculosis, fungal infections, coccidomycosis, and there are due to some local irritants like and the elementary conditions like Crohn's disease, Whipple disease. So, as I said, the PET, they should not be mixed and you should not be confused with keeping in a view, because once we advise someone PET CT, we always have that preoccupied mind that the patient has a malignancy. First thing that should be rolled out.
Sure. So, thank you, Kamaljeet. I agree with you. I'll turn the question a little and ask Anuradha. So, Anuradha, suppose you had a patient whom you were investigating for early lung cancer, and you found a nodule which shows high uptake. The greater risk, obviously, is lung cancer. So would you go down the lung cancer algorithm in this case, given the fact that that's the greater of the evil? Or would you actually do, if there's a history of TB, for instance, or if the nodule has the characteristics of fibrosis that Nagarjuna spoke about a little while ago, how would you deal with a 2 centimeter nodule which has high uptake? Patient has a positive history of pulmonary tuberculosis in the dim and distant past, 20 years ago. There's a little bit of fibrosis around the lesion. What would be your take? It's 2 centimeter in size, so far bigger than the 8 millimeters that Nagarjuna spoke about. What would be your take? Would you just repeat a CT in 3 months' time, repeat a PET CT in 3 months' time, or would you say, hey, I have access to these modern tools, I'll go ahead and sample?
A nodule of 2 centimeter with a high uptake, with a bit of history of old pulmonary COX in the past, which is there probably in many of our patients, would not deter me from taking a biopsy from this case, because first of all, if you want, it can be accessible. You can send to people like Nagarjuna or to me for doing the biopsies. We definitely have wherewithals. And other centers also, if they are not there, but 2 centimeter, I would be a little more cautious.
Yeah. So I'm glad you said that, Anuradha. So the carry home message for the audience is that if you are, even if your patient has a history of TB,
True.
However, if your patient has risk factors, if your patient has a solitary pulmonary nodule, which on PET CT has high uptake, sample the nodule, because that's the greater of the evil. Your patient might have a lung cancer which is untreatable in a few days' time. And if you have access, or if you don't, send the patient across to someone who is actually able to do these procedures and sample the nodule, because that's the greater of the evil. And I think that's a strong message for the audience. Don't think this is TB as your sort of stand back option. Think it's cancer, because that's the greater of the evil. You might miss the chance of curative surgery if you miss out on a solitary pulmonary nodule, which ultimately turns out to be lung cancer. Let me come to you, Nagarjuna, with the question which is there in the chat box a lot of times. So the question is, you have a central lesion. You spoke about this, but if you can sort of summarize in 2 lines and tell the audience, you have a solitary pulmonary nodule. There's lung parenchyma all the way around. So in a center which is non-Yashoda, say the CK Birla group of hospitals, we have radial EBUS. We don't have navigational bronchoscopy as yet. We have transthoracic CT biopsies available to us. So what would you recommend we do with the 2 centimeter centrally placed nodule with lung parenchyma all around it?
Okay, I think here, sir, looking at the CT characteristics is very important. So the most important thing is to get a good CT scan. So whenever you're planning a bronchoscopy or a biopsy for a nodule, I think it's a high volumetric CT, which is what is required. And if you find a bronchus sign, then definitely I think a bronchoscopy radial EBUS is the answer. And I would say, if on a good quality CT, and up to 40 to 50% of the nodules, you do end up seeing the bronchus sign, and you can chart out a map, a pathway to this nodule. Second thing is the size. 2 centimeters or above, I think is a reasonably good size for getting it diagnosed without a navigational plan.
Sure.
The smaller the nodule, more is the requirement of these high-end gadgets, this navigation and all. Large nodule, lesser is the need of these navigational platforms.
Sure.
Third thing is the location. Closer to the pleura, the more closer to the pleura it is, the more difficult it is for us to go through a bronchoscopic approach. It is not that we cannot. We have hit nodules which are abutting the pleura also, but then there are exceptions. So if it is in the peripheral 1/3, I might still say if you don't have a CT bronchus sign, you go for a CT guided biopsy. If you have a CT bronchus sign, irrespective of the place where it is, you can go for a bronchoscopic approach. If middle 1/3, then definitely bronchoscopic approach should be chosen over a CT guided approach unless until you don't have these things. I think these are some of the things which we have to consider. One is the bronchus sign, 2 is the lesion, 3 is the distance from the pleura. I think these are the things which we determine.
Do you think the fluoro imaging can also help along with it, sir? Because the cardio people...
Two roles. See, all nodules may not be seen on fluoro. The very simple way is if the nodule is seen on an X-ray, it is likely to be seen on the fluoro. If you have a nodule which is not seen on X-ray, which is seen on CT, you won't see it on fluoro. Okay, so fluoro will help us in 2 ways. One is if the nodule is
location
enough, yes, you can see. The second way how a fluoro can help us is to know whether your guide sheath is actually in place or not. Because in radiolibus, once you put the radiolibus probe and you see the lesion, then you put a fluoro and then you identify where your probe is.
Probe is going.
You're able to see the lesion actually, but you know where your probe is. And then once you remove the probe and then start doing the brush and biopsy, you can just reconfirm once or twice whether your biopsy and brush are in the same place as the probe was. So that is how a fluoro will probably help.
So Nagarjuna, you've answered my question. We actually do all our radiolibuses with fluoro. The Shyam who's joined us recently does that for all our patients who have a radiolibus. I'll just quickly move on, Anuradha, I'll come to you. So if you have a comment, you can add it to the question that I'm going to ask you. This is something you said a little while ago, which I think is important for the audience. So you happen to pick up a solitary pulmonary nodule in someone who is not fit to have a surgery done. So my question to you is, what would be your palliative approach? What sort of conversation do you think we should have with the patient at that point of time? And how far would you go in trying to establish a diagnosis of cancer in the solitary pulmonary nodule, let's say of 2 centimeter size again? Patient not fit for surgery.
Is that for me, sir?
Yes, Anuradha, sorry.
Okay.
Yeah.
So, sir, as I said that a 2 centimeter nodule has a high risk of being malignant here. So the informed discussion or the shared discussion with the patient is the foremost thing that I would do. The first thing that you have to tell them is that the likelihood of this being malignant. And I would, in my approach, I would like to also convince them for a biopsy in either ways. If that biopsy turns out to be malignant, definitely, and the patient is not surgically fit, then there are other things like radiotherapies or ablations are there where you can go in for SABR or the RFAs and all are there, or the radical radiotherapy only, which can be offered to them if they are not fit for surgery. But definitely, I think we should give our full impetus on at least explaining to the patient how it would go. And these are the things that I would follow.
Yeah, grand. I've got nothing to add. That's a perfect answer. Thank you very much. Strong message. I'll come to you in a moment, Nagarjuna. I'll just ask Kamaljeet a couple of... Yeah, sorry, go on.
No, and I say there are 2 things. Fitness for surgery is one. Fitness for biopsy itself is another thing.
Sure. So my question more was about... So I think in today's day and age, Nagarjuna, you and I know, and that there's very, very few people who would not be fit for a procedure. That would be a very small minority of people. They might not be sort of fit for surgery, but to do an EBUS or to do a bronchoscopy with the endobronchial sampling, I think is a relatively simple procedure for us nowadays. And we're talking about a minority when we cannot sample at all. So yeah, so fair point, but I think we're talking about a small number there. Kamaljeet, a couple of questions for you from the question box, and we're coming in the last 2-3 minutes of our very, very interesting panel discussion. So one question is about the coexistence of TB and lung cancer. So one of our questions, one of our audience, Dr. Meena Hingorani, says TB and lung cancer can coexist. How would you separate these two? That's one question. The other question is about scar carcinoma. So TB scar left behind turns into an adenocarcinoma at a later date, something that we've studied from our sort of postgraduate and MBBS days. So thoughts, 1 line, 2 line thoughts about both those questions.
The lung cancer and TB, yes, of course they can coexist, but yes, as I said, every patient should be in India when it's endemic for tuberculosis. We always go for the routine sputum for AIB, CBNet, and all those procedures. Yes, but we should also keep in mind that malignant cavitary lesions do exist, because which causes central necrosis, which causes the necrosis, and they cause the cavitary in between, which may represent as and which may exhibit as tuberculosis. But we should not hesitate to diagnose them if it is supposed to be CBNet negative, or it turns out in GeneX, but it turned out to be a negative. Yes, of course, we should go with the approach of biopsy, bronchoscopic approach for the ball cytology to check whether this malignant cells are evident or not.
Sure. Sure. So Kamaljeet, lovely answer. So what we are trying to tell the audience and our colleague here is that you would have to be very, very unlucky to have lung cancer and TB at the same time. And there's no way you will actually sample 2 different lesions in the same patient at the same time to find out whether they have lung cancer and TB coexisting or not. There is no appearance which would exclude TB. There's almost no appearance that would exclude lung cancer. And I think sampling and biopsying in the right sort of patients is very, very important. So lovely answer. Second question, scar carcinoma, Kamaljeet. Kamaljeet, scar carcinoma, your thoughts?
Sir, scar carcinomas, as I said, there is a process of angiogenesis and healing, all the which is in the post-tubercular patient, which is more evident. Yes, any kind of uninhibited process which repeated injuries to that particular site may give rise to the suppression of the repair, which may damage the cell walls and which may damage the cell wall and cause error in the DNA repair of that site, which may become a precursor for the oncogenes, may become the precursor for the oncogenes, and may turn out to be a scar carcinoma.
Sure.
To be very brief in that.
Yeah.
I think more we look for it, we'll get it, sir. That is also an answer to it.
So Anuradha, absolutely agreed. So I think the clinical scenario that we're all talking about, Kamaljeet is talking about, you're talking about, is someone who's had TB in the past, has a scar on the lung that we know of, gets new symptoms. You see the scar enlarging in size. You get a CT done. You get evidence that there are some features of malignancy that Nagarjuna spoke about in his talk. That lesion needs to be sampled. Scar carcinoma is now an archaic term. It's an ancient term. But for the reasons that Kamaljeet very nicely spoke about, scars can turn into cancers in a later date. And if there are symptoms, they need to be followed up for sure. So thank you very much. And let me sort of take a line each from each of you as a message about early lung cancer from today's discussion. And then I'll summarize and finish. So we'll start off with Kamaljeet this time. So Kamaljeet, your message, 1 or 2 line message to the audience as to what your take home is for early detection of lung cancer in our country.
Never hesitate to diagnose in appropriate manner, sir. And your patient should be well informed, and they should be well counseled once it is diagnosed. And so for the proper, so that they should not be like we have in a tuberculosis, lost to follow-up cases in cases of malignancies.
Great. Nagarjuna.
So before I say my line, I think there is a message from the tech team also to say that there is more than 1250 audience who have joined this webinar. So I think we should thank every one of them for being there till 9:40 now. So the take-home message from my side will be that if we have any lesion which is incidentally picked up for any screening purposes which are currently there in our country, I think we should interpret it in the clinical context, look carefully at the clinical history, stratify the risk of the person, assess the radiological characteristics of the nodule, and then choose the correct biopsy technique so that we'll get the correct diagnosis.
Great. That's a lovely summary, Nagarjuna. Anuradha.
I completely agree with both Nagarjuna and Kamaljeet, and I'll add a little bit that a realistic, a little non-emotional and an emotional balance of approach is required probably to go ahead with any such lesions. Rest all has been spoken about.
Sure. Great. So my carry home message or my summary is that we probably need to come up with a white paper, and nothing me this to try the thoughts of a white paper on how lung cancer screening should proceed in our country. I think we came up with lovely thoughts today, and the audience contributed with their questions. And starting off with whether we can have a lung cancer screening program in our country, and I think the answer is yes. What we do with nodules, which might be granulomas, and we had a lot of thinking around the process, and we said, what could be the factors which would help us to identify an intermediate group of individuals who are followed up for a less time, but still get into the screening program. We then talked about how we would go about following these patients up. And we said from the studies that I quoted that a year would probably be optimal for follow-up in these individuals. We spoke about the various investigational techniques in trying to diagnose these conditions, pick up early lung cancers which are potentially curable. And we came up with some sort of an algorithm as to how about doing it. Nagarjuna did a beautiful job in talking about the modern techniques that are available. And we also said that we need to be as minimalistic as possible. We spoke about the constraints that we might have with the lung cancer screening program in our country, given that there's the private sector, the government sector, and the other sectors represented by Anuradha in the form of the army. And there needs to be some sort of an amalgamation of these centers to offer lung cancer screening to our population. And last but not the least, we picked up a population where we think lung cancer screening is going to be useful. So those are the points that we ticked. I need to thank the entire audience for being with us. 1250 people on a niche topic like lung cancer screening is kudos to the CCI members for being in such large numbers in a program which is overshot now by about 13 minutes. So thank you everyone in the organizing team of CCI. You guys rock, you do a great job. And thank you to Anuradha, Nagarjuna and Kamaljeet for being with us today and sharing your thoughts on early diagnosis of lung cancer. Thank you very much, guys.
Thank you so much, sir, for the excellent moderation.
Thank you, sir. Thank you for such a smooth flow and covering all the aspects. And I also thank the CCI team for giving us the opportunity.
Thank you. Thanks a lot.
Thank you, sir.